This is Blood and Cancer, the official podcast of MDedge Hematology Oncology, where we discuss the latest research, treatment considerations, and other issues related to hematology and oncology.
So welcome to the podcast. You're listening to Blood and Cancer. I'm your host, Dr. David Henry. In our continuing series this December of recent updates from our American Society of Hematology, or ASH meetings, which were the first weekend in December, I'm delighted to be speaking this podcast with Dr. Kristen Sanfilippo, who's an assistant professor of medicine, hematologist at the Washington University School of Medicine. So Dr. Sanfilippo, thanks so much for taking the time to join us.
Thank you for having me.
Well, you're very welcome. So much an incredible pivot this year for us as hematologists, going from whatever we're going to talk about to how does COVID affect what we were going to talk about at our meetings. COVID comes in February, March, and here we are in December with a lot to talk about. And you recently chaired at these meetings a session on thrombosis and cancer in COVID. And so what was the exact title of that session?
So it was an outcomes research session, which is numerically session 904, which there's lots of 904s, but this one was outcomes research for non-malignant conditions with the title Venous Thromboembolism Associated with Cancer and/or COVID-19.
All right. So I know there were more than just these three abstracts we wanted to discuss, but I thought we might just go through three that caught my eye, and if you want to add another, that's certainly okay. So our first one was abstract titled 202, number 202, Performance of the Khorana score to predict 1 year risk of venous thromboembolism in over 2 million patients with cancer, really a large number, of course. And to remind our listeners, I've always been a fan of this Khorana score. It's so simple. And so it's a score based on 5 parameters: the site of cancer, whether it's high risk like GI or not GI, platelets over 350, hemoglobin less than 10, white count over 11, or a BMI 35 or more. So could you talk a bit about that abstract, what they said and what you thought it meant?
Yeah, happy to. So I will say that there are several risk prediction models to try to determine which patients with cancer have the highest risk of venous thromboembolism, with the goal being that we know that in general, many studies have shown that thrombosis in patients with cancer is associated with increased morbidity and mortality. So the goal of these models is to predict the highest risk population so we can intervene with something such as low dose thromboprophylaxis, which has been shown to be effective and safe in larger randomized control studies. Of all the risk prediction models available in cancer, the most validated risk model is the Khorana score. So this was a wonderful data set for those of us who do outcomes research. It was the IBM Watson data set in this abstract, and it contained over 2 million patients with cancer, presumed ambulatory care patients. And so then the authors utilize this data set to validate the Khorana score in this patient population.
Go. I was just going to say, I looked at the abstract, so you'll elaborate. I think they concluded it aids and it's a weak predictor, but it seemed like there was some predictability to it. So I'll let you go ahead and describe what you heard.
Yeah, so I think there's a couple of important components to think about when you're interpreting this. So the overall conclusion of the abstract was that the Khorana score only moderately predicted thrombosis in this patient population. If you look at the I think they presented hazard rates. I don't have it up right now, but if you look at it by the individual variables, and then if you look at the risk of thrombosis over time by Khorana score, there was a nice linear risk showing that as your Khorana score increased, the incidence of thrombosis increased as well. They then use a statistic called an area under the curve, which is really, it's the ability of a model to discriminate the patients that are going to develop a clot versus those that aren't. So, and then they also presented sensitivity and specificity, which showed that, overall, that the lower the score, I think there was poor specificity, and the higher the score, there was poor sensitivity. But a couple of points to think about with this abstract. So one, the Khorana score was actually developed to predict the risk of thrombosis within the first 3 months of starting systemic therapy. So we know in patients with cancer that the highest risk of thrombosis is really that first 3 to 6 months post-diagnosis when they're starting therapy, sometimes when they're getting other interventions such as surgery. So when Khorana and colleagues developed the score, they actually looked at risk over a 3-month time point, which is important when you think about the variables that are within the model. They subsequently, I think at ASH 2 or 3 years ago, 2017 or 18, looked at the ability of the model to predict thrombosis over 6 months, and it looked relatively good. So when we had the actual studies that used it to try to assign prophylaxis to patients, they were allowed to do that 6-month time period. So this study looks at thrombosis over a 1-year time point. When you think about the variables, the high risk features that you're including in the score, it's things like you mentioned, platelet count, hemoglobin, weight, all of these things are not fixed. So something like gender or cancer type, other variables we sometimes see in models. In the Khorana score, there's also cancer type. That's not going to change. And so that's okay to look at it over a longer outcome. But a platelet count in the beginning that's presumably associated with the new diagnosis of cancer may be significantly different 9 months later, and thus not be as good at predicting outcomes. So I think that's one area of concern, that I have in general about taking away this take-home point that the Khorana score only modestly predicted. A couple other things. So we talked about that. They also started the clock for blood clots at cancer diagnosis and not at the start of systemic therapy. And we don't know that all the patients within that cohort received systemic therapy. So, I mean, I just know from doing VA data and for example, looking at clot outcomes in patients with pancreatic cancer, a large majority of patients who are diagnosed with metastatic disease never receive therapy. And so we also know that certain chemotherapy agents are risk factors for cancer. So you're kind of taking out a risk, a known risk time period in some of the patient population.
Let me ask you a question. You mentioned pancreas cancer. When I see a metastatic pancreas cancer patient, I'm sure it's going to be a high Khorana score. They have such a high chance, I think, as they start therapy with, as you mentioned, the chemotherapy itself can be clot provoking. So I try and get on some kind of prophylaxis. Dr. Khorana and others have published using some of the novel direct oral acting anticoagulants versus not. So what are you doing? Are you absent guidelines? We have the data, but no official guideline in the not yet clot outpatient setting. We know inpatient, we know post-op, we know post-VTE. Are you prophylaxing going in with anything, and if so, what?
So I will give the disclaimer that most of my clinical efforts are for patients with thrombosis. So they've already developed thrombosis. I will do some kind of risk stratifying. I do treat patients with genitourinary cancers, which luckily tend to be a lower risk population. In general, prostate cancer patients are starting hormone therapy. But if I did treat some of these high risk cancer patients, I mean, I think these studies have very nicely shown that it does decrease the risk of thrombosis, and that the intervention is relatively well tolerated. With there is a slight increased risk of bleeding, but I think overall risk benefit is a discussion that should be had with all patients, especially those with the higher risk malignancies.
So would your takeaway from this abstract be that in a large data set, 2 million patients, that yet again, we need to worry about certain types of patients? This kind of helps inform that decision as well, and to think about some kind of prophylaxis as we develop more data.
Exactly. Yeah. I think so. We have the Cassini and the AVERT trial, and several subsequent meta-analyses of those two trials that show that this is an effective intervention in patients with a high Khorana score. And so I think that providers should at the very least be discussing doing this intervention with their patients and then making an informed decision with risk benefit, discussions with their patient on what to do. But the data we have right now favors giving prophylaxis.
So let's move on to the next abstract, number 204, incidence of and risk factors for venous thromboembolism among hospitalized patients with cancer and COVID-19. A report from the COVID-19 and Cancer Consortium, the so-called CCC-19 registry.
So that was Dr. Lee and colleagues with I think it's the COVID Cancer Consortium, which has been a really nice collaboration and development with a large group of individuals that's led to some nice papers that have come out looking at outcomes in patients with cancer who develop COVID-19. So Dr. Lee and colleagues, their overall goal was to try to identify really the risk of thrombosis in patients with cancer and COVID-19 admitted to the hospital. And then if they could identify features of this patient population that made them at higher risk. And what they saw really amongst the cancer patients was that the trend was relatively similar to the general population that we've been seeing, in that patients who have higher levels of critical illness, so particularly ICU patients or those that would tend to meet ICU criteria for admission, had higher rates of thrombosis comparatively to those who were admitted to the general ward. When they tried to look at features of the patient population with cancer that increased risk, so things such as recent treatment with chemotherapy, again, they looked at the classification of risk of cancers, and they used the Khorana risk categories, so such as very high risk, pancreatic, stomach, esophageal, and found that those very high-risk cancers, again, had higher rates of thrombosis when they were admitted to the hospital with COVID-19. And the model they have, which is a very preliminary model that he presented at the meeting, actually looked like it's going to do a very nice job discriminating. And I know they're refining it further. They're considering, based on another presentation within the same session, investigating whether or not race is associated with a higher risk of thrombosis overall. So I think they're going to develop a very nice risk model. Whether or not that will change practice, I think, is to be determined. The randomized studies that are looking at prophylactic anticoagulation versus therapeutic anticoagulation in COVID-19 are really not discriminating based on cancer. And so we may be able to take these very large studies and shift out the cancer patients and look at his outcomes based on that.
Yeah, certainly agree. And this reminds me to mention, we interviewed one of the principals in the COVID-19 and Cancer Consortium, the CCC-19 registry, Dr. Brian Rini, a few weeks ago. And just as you said, they have this large database, which they're going to be mining, and more papers and abstracts coming out to tease out COVID and cancer, and what is the implication for us hematologic malignancies. You as a hemonc straddle both sides of the street. So I think this was interesting and a work in progress to come out with who should get what in terms of watch out for and or prevent.
Exactly. Yeah, I think that this group is collecting some wonderful data, and there's going to be many publications to come.
Okay, so the third one I thought was interesting, and then we'll see if you have another one that you liked as well, was number 206, abstract, anticoagulant and antiplatelet use not associated with improvement in severe outcomes in COVID-19 patients. So what did you think of this one?
So the overall conclusion of the authors was that we need prospective studies to really look at this question, which I wholeheartedly agree with. And those studies are underway through both NIH and non-NIH studies, including the ACTIV-4 series that's going to be looking at questions such as in the outpatients, aspirin versus anticoagulation versus placebo in terms of outcomes, and then the inpatient regimens, which is really looking at prophylactic dose anticoagulation versus therapeutic dose anticoagulation. With many of these studies, the main outcome really being disease-specific outcomes as opposed to venous thromboembolism. So admission to the ICU, ventilator use, et cetera. So, and that was the goal of the authors when looking at this. So they were trying to investigate this outcome by assessing what happened to patients who were already on these interventions for an alternate indication. They started out with a cohort of 28,000 patients and then found the patients who were either on anticoagulation or antiplatelet therapy or both. And they ended up with a cohort of about 1,000 patients, which is a really nice size cohort. But overall, they really found that aside from, I believe it was ventilator use, that anticoagulation was associated with a decreased risk of ventilator use, that these variables were that anticoagulation and antiplatelet therapy were not associated with significant improvements in outcomes in terms of, so the outcomes they looked at were death, inpatient admission, ICU admission, ventilator use. So in general, they were overall not associated with it. And I would say that the design of the study, while a great cohort could be improved upon to really look at their question. So we know that patients that are on anticoagulation and aspirin at baseline are on such therapy because of probably an underlying comorbidity that is really going to put them at higher risk of any of these outcomes. So you're comparing a high risk population to a slightly less high risk population. They did attempt to adjust for that by adjusting for hypertension, diabetes. They looked at weight, gender, things that we know that are higher risk, but they didn't look at things such as history of venous thromboembolism, cardiovascular disease aside from hypertension, history of CVA, all of these things that have been shown in other studies to be predictors of mortality and worse outcome, especially in a critically ill population. The other thing is they used a study design where they were not fairly adjusting for death. And we know with COVID-19, there's a very high mortality rate, especially in ICU patients, and you can't go on a ventilator or you can't clot if you die. And so really a design needs to account for that. And so I think they needed to change their design in general. And so my take home point from this would be that this question remains to be answered. And there are several clinical trials that are starting to accrue and opening that will help give us high level evidence regarding this.
So I'm thinking, beautiful summary. What do we know and not know? So, of course, not all COVID patients are admitted to the hospital. Someone has some symptoms, suggestive, you order the test, you're the primary care, the hematologist, oncologist, if it's a patient with those diagnoses, they get the test, they're positive. How do you feel? Not so bad. Go home, quarantine, stay away. So we don't think that population should be on prevention therapy. And I guess we're going to study what if that patient happens to be in atrial fibrillation and already on a blood thinner or has coronary disease and stents and on Plavix and aspirin. So those need to be gotten into some kind of cohort study for your outcomes research versus the other patient I'll pose and I'll let you comment is the one who is admitted and is pretty sick, but in step down, not ICU. I think Ash is trying to develop, should we intervene there to try and head off what's coming of a thrombosis type. So those two patient types, how are you thinking them through?
Yeah, and exactly. And so this study started with outpatients. I think the trickiest patient population is the first patient you described, where they're diagnosed in the outpatient setting and they don't have any kind of red flags that would require admission to the hospital. And so they're told to go home and recover. And I think especially in the beginning, that was happening. Now, more institutions, including ours, are using these home monitoring programs to where they're calling the patient every so often to follow up on symptoms and severity of disease and trying to triage them more to the inpatient setting earlier if needed. But I think that patient population is very hard to capture outcomes in. So I think we're really lacking data in that patient population. there's a trial that is now open and is accepting sites, and their goal is to enroll 7,000 patients. So I think anybody who's listening who is interested in this, if you're at an institution, trying to include your institution in the active 4 outpatient clinical trial is wonderful. The way they're doing it is really making it hands-off and relatively easy to kind of, once the patient's on, they're on and they take over. And I think that is gonna give us an answer to the question. I think right now, with the available information we have, we don't know what the best practice is. If the patient is admitted to the hospital, this is an area where we've seen numerous studies published within the literature looking at the incidence of thrombosis. And these have all been retrospective, so not looking at an intervention. And the American Society of Hematology released the first evidence-based guidelines. There are many guidance statements that you can find, but the American Society of Hematology took all the available information and put it into a systematic review and meta-analysis, and the details of that will be forthcoming probably within the next 4 to 6 weeks in Blood Advances. But based on that analysis, right now, the recommendation is for prophylactic dose anticoagulation over intermediate or therapeutic dose anticoagulation, with the caveat being that no 2 patients are the same. And so if the treating provider assesses their patient to be at a very high risk of thrombosis or have high risk features, then they should be empowered to increase the dose as they see appropriate. And then the third group is what happens when you discharge the patient home from the hospital. I think with this second surge, hospital systems have been a little bit more prepared. And so we're not seeing, we are seeing people reach capacity, but kind of certainly not the situation that was initially in Italy or New York, where you could postulate that patients were being discharged home still very ill because there was no capacity for them in the hospital. And I think that patient who is getting discharged home still very ill is much different than a patient who's relatively well recovered. We know that medical patients admitted to the hospital have an increased risk of clotting after they're discharged. And we've seen prior studies that have looked at those who kind of had high risk factors have improved outcomes with being discharged on prophylaxis for up to 30 days, depending on kind of what arm they were in. But they also had double the risk of bleeding compared to the patients that weren't discharged. In the few number of studies that have published the rates of thrombosis post-hospital discharge, the rates have been very low for COVID. But these are a small number of studies, again, all retrospective. And so all of these questions, I think we really need clinical trials to look at.
A lot of guidelines with about 15 different points coming up soon, thanks to our mother organization of the American Society of Hematology. Well, I found those 3 very interesting, and your comments even more interesting. Anything I missed, or do you want to mention to give an honorable mention?
I mean, I think that that you kind of covered on the kind of practice changing ones that were presented during the session. It was a great session. I believe it's still available. I think people can still sign up to watch. If you registered for the meeting, they did extend the viewing time, and so
90 days, I think. Yes, I'll be after Christmas, locked on the computer in the office. Well,
right,
Kristen, really thank you for joining us. We've been speaking with Dr. Kristen Sanfilippo, who's assistant professor of medicine, a hematologist oncologist practicing Washington University School of Medicine, and located mostly at the VA or entirely?
No, I'm actually, I'm 80% at Washington University and then 20% at the VA.
Wonderful. And to remind our listeners, these citations will be on our website at mdedge.com/hematology-oncology. So everyone, thanks again for listening. Kristen, thanks again so much for joining us today.
Thanks for having me very much.
That's it for this episode of Blood and Cancer. Blood and Cancer is produced by MDedge Hematology Oncology editor Jennifer Smith. All of our podcasts are produced by MDedge executive editor Kathy Skarback.